And I looked at the registration form back there, and I realized I'm talking to an abundance of students. I'm also looking at you and seeing that everyone is thin, or at least almost thin, which is the new dietetics of today, because it has not always been that way, believe me. But also, I'm always interested in what you want to get out of a conference. I like to know, and you'll notice that first of all, I'm going to be talking about obesity and mental health. I'm not talking about whatever the title is on that. That's what you get to do when you're older. You just change titles. But when I started reviewing for this topic, because actually I'm much more knowledgeable about how to feed babies than what to do with the mental health population, although I do certify all right in that, because I am a consultant at the Glenwood Mental Health facility here in Birmingham, which is a very, very interesting facility for mental health, and particularly for autism, for the autism spectrum. But I always like to know what it is you like to get home. I always like to know how I'm going to use whatever somebody tells me. So I will try to make this as practical as possible. And if you do want to ask questions, you just have to ask the question, because I don't have my cell phone set up back there. I do have a cell phone. That's one thing I do that's relatively high tech. But you will see that my slides are going to be very old-fashioned and straightforward. So I just want to prepare you for that. But as I thought about this topic, I was remembering some historical things about mental health through the years. And one of them was that in 1970, when I was working in the position that Susie Gertz is now working in, Dr. Alan Cott came to Birmingham, and he was an expert on schizophrenia and mental illness. And one of the things that he did was he came in and gave a series of lectures, because his philosophy was that everyone needed to be on megavitamins and absolutely sugarless. And so as I reviewed the literature, actually, we all kind of poo-pooed that. But actually, today, we know that you don't have to be on lots of vitamins, but we do know that there's a relationship between vitamins and mental health, and actually perhaps in the prevention of mental health. So I couldn't help but thinking about that. And as a result of the doctor coming to Birmingham, and they now have an Alan Cott School at Glenwood, and the Glen Ireland family gave all the property for this school. And I encourage you to sometime come out and visit, because it is a very nice facility with lots and lots of cottages. And that, from a historical point of view, is important too, because when we first started the Spark Center, which was in 1969, we went to Tuscaloosa to visit the Bryce Hospital for mental illness and Partlow for mental retardation. Both of those institutions had from 1,000 to 1,200 patients in them. And I can tell you that nobody was paying any attention to essential fatty acids, sugar, vitamins. It was a warehousing thing. And so it was a wonderful thing that those institutions decreased in size, some went away, and we have a partially good, I would say, system for individuals with special needs today. And to have more and more research is certainly something we need. So, I just wanted to, for this talk, for you to clarify mental health and mental illness, because I think there's a difference. And I'm assuming that everybody in this room has good mental health. Maybe, and if you don't, you can tell me later. But I think we do need to know a difference, that probably all of us have a few episodes where our mental health is not as good as it could be, as our physical health is not always as good as it could be. I want to talk about the behaviors in mental illness which might lead to obesity, and discuss what our role is in treatment. Now, you've already heard some of that from Dr. Carson. And then I particularly want us to think about family intervention. Because when you're counseling a person, if you do not look at the whole person and look at the family and look at the environment, your counseling usually doesn't go very far. So, this is a definition for mental health. I guess I'll put this back up. This is, and it helps determine how we handle stress. I was a little bit stressed this morning coming over here because I'd had one of my usual stress nightmares, which is when I'm under stress, I'm always out hunting for my car. And I was hunting for my car in my dreams all night. And how did I react to that? When I woke up this morning, the first thing I did was shoot down to the kitchen to get a cup of coffee to get that caffeine need fixed. And that's how a lot of us handle stress. If it hadn't been so early, I might have gotten a piece of chocolate candy. And then we have to think that, as we were just shown, that mental health is important from childhood through adolescence and through adulthood. But mental illness is different. And we know that poor mental health can either be precipitated by mental illness or can turn into mental illness. And we just put up here a few of the examples of depression, anxiety, schizophrenia, eating disorders is considered a mental health disorder, not necessarily an illness. Addictive behaviors. And we know that addictive behaviors can turn into mental illness, and then we've added autism. In some of the listings, attention deficit, ADHD is listed too, and that is a very prevalent type of disorder, particularly among young children in school, and I actually think I must have grown up with ADHD, and I know a lot of adults that today say they think they have ADHD, but the good news is they're not on medication. And the ongoing signs, cause, frequency, and if the mental illness is bad enough, there's an inability to function. And that is a population that we see at Glenwood, that most of the individuals there are not able to function within our special education system or within our communities because of their acting out behaviors, which are precipitated by whichever of the mental illnesses they have. So how do we know the numbers that we were showing? You were just shown some numbers. Well, there have been a number of surveys that are ongoing, and I think it's very important for us to understand that those are coming out of the government, usually Department of Mental Health, the maternal health department, but you have interviews, and most of your surveys are done by telephone interview. Very few of them are actually face-to-face. But if you'll notice, one of the popular ones that, as you work in public health, you'll learn about, is the National Health and Nutrition Survey examination, which is called HANES. And They sample about 5,000 people per year, and they look at a variety of factors that are considered under the aegis of the Center for Disease Control. And then you have national health interviews, and they sample about 43,000 households. Now, what are the survey topics? I was impressed as I was reviewing the literature for this, how many various things they actually interview for. Depression, conduct disorders, eating disorders, drug and tobacco use, alcohol use. And that has become of increasing importance, ADHD and anxiety. Now, when I talk about ADHD, you know, I don't know if you've ever had the experience yourself or had the experience of someone in your family being in school and the teacher sending home a note saying, your little child will not sit still, they're not comprehending the reading, they're just all over the place. I think your child has attention deficit disorder, so you need to take the child to your pediatrician and get him on medication. That happens a lot and is something that never happened much in the past, but has become a much trendier issue today. So that child is being put on a medication early in his life or her life. But ADHD is actually more prevalent within the male population than in the female population. And then we have the highest incidence that they have found in their surveys has been substance use disorder, which I would not be surprised at, anxiety disorder, ADHD, and conduct disorder. The individuals that we see in Glenwood were largely conduct disorder, and because in your school system, with the special needs law, where all special ed children with special needs are in special ed classes, many of those programs cannot handle these individuals, and so that is how they go into some type of facilities such as Glenwood. And they do have facilities like this all over the state, and there is a State Department of Mental Health and Mental Retardation that provides for the funding of these, in addition to funding for group homes. Now let's just look at obesity, because I'm talking about obesity and mental health, or am I talking about mental health and obesity? And it's sort of like, which came first, the chicken or the egg? Well, we all need to know things about obesity, childhood obesity, because we certainly have studied about obesity in our profession, in the academy. I think we've almost been preoccupied with obesity. And so is there a relationship between obesity and mental health or mental illness? And if you'll notice here, this is one of the latest of the surveys done, where they found that you had overall, for 2 to 19 years of age, 18.5 million% of children in that range were overweight or obese. And there is a slight difference between the definition of obesity and overweight. And you'll notice that in children from 2 to 5, 13.9% of the survey, but by the time they got up to adolescence, it's getting much bigger, which is, from a standpoint of a pediatric dietitian or a nutritionist that has focused somewhat on children, early intervention is the place to start in the prevention of obesity, and I think in the prevention of mental health, in the promotion of mental health and the prevention of mental illness. And it is not something that has always been a part of the healthcare system. This is how do we define obesity? How do we define overweight? Well, according to the American Academy of Pediatrics, normal weight has we use the BMI. Now, there are people that criticize the use of the BMI, thinking that it doesn't look at body fat enough. And of course, you can always add skin folds or various tricep skin folds. It's a variety of skin folds to look at the fatness. But the BMI is really a screening measure. But you'll see that normal weight is 19 to 24, overweight 25 to 29, and obesity 30 to 35. Now, I don't know whether all of you have the BMI app, but one of the ways you can make yourself very unpopular, if you do have a BMI app on your cell phone, one way to make yourself very unpopular with your family is to say at dinner one night, "Oh, tell me your height and weight and I'll tell you your BMI." That's almost the reason that as a practicing dietitian, I had to get rid of my skin fold calipers, because I was always wanting to do skin folds on my grandchildren. And that is never something that's a good idea. But it is not uncommon, it's not easy, most of us know, to get up to that BMI in the 30 to 35 range. And it's hard to get down to 19 to 24. There are population differences in obesity, as I think most of you know. Like the highest rate is among the Hispanics. And then the next highest is between non-Hispanic the black population. Non-Hispanic whites are down to 14.1, and the Asians have the lowest of 11.0. And this is from a survey recently done by CDC. There's also a relationship between your economic status and obesity. And I think within our profession that we have been alerted to being more cognizant of the economic status of the clients that we're working with. Because if you're working in obesity counseling, say, or weight management counseling with a low-income family, I don't think you're going to send her off to you need to be very mindful of the kinds of recommendations to make related to food selection. You need to know if the person's on the food stamp program, if the children are on, if the family's on the WIC program, because that will help you in your counseling. But we know that many people in low-income areas have a low rate of cooking at home, that they're very dependent on what's in the neighborhood that they can pick up, and that the children, they don't go home often to the mother or father or someone there saying, "Oh, let me fix you an apple with a little bit of peanut butter on it." I mean, more likely you're going to stop at the store and pick up a bag of Cheetos or some kind of chip. Now, I'm not meaning to sound that I'm being judgmental about that, but many studies have shown that in our low-income areas, they are very dependent on picking up processed foods or foods that are quick and higher in calories, and especially higher in sodium. So you'll notice, though, that the rate of obesity is lowest in the high-income population. And there's a second reason for that, I think, and that is that the high-income population sometimes is more correlated with a higher education, and so that the parents are all over that internet and watching television and all those cooking shows that are now on television. And I think we're going to hear all about media on Thursday or Friday with Beth Kitchens, who is our dietitian that's on Channel 6 at least once a week. So why are we concerned about obesity? Well, now I know I'm preaching to the choir. I know that you know all of these things and why it is not good for anyone with a mental illness to have medical conditions superimposed upon their treatment programs. And this has been particularly true to make sure that there is a correlation between the medical status of that individual and their mental status. So, is there a link? Is there a link between mental health and obesity, or obesity and mental health? And I drew this. That's why it's not better. I'm going to go back and take lessons after watching the first two presentations this morning with their phenomenal slides. In fact, if there's anybody out there that does this, contact me, because I'll really pay anything to make my slides look better than this. But this is my little artwork here. Okay, so what is the relationship between mental illness or mental health problems and obesity? And one of the things that obesity rates have been found to be higher in people with mental issues. Whether the obesity contributed to the mental illness or the mental illness contributed to the obesity is the problem. But if obesity has contributed to mental illness, and certainly we think it has contributed to eating disorders, the poor self-image of the individual, the lack of activity, the lack of physical activity, and then biological disruptions that lead to medical problems. One of the surveys that has been done has been done on physical activity, and it was and in one of the surveys, 8% of the sample did not have any physical activity during the day. And this is in a 0 to 19. Well, let's start at 2 to 19. And and only about 14% were having any kind of daily physical activity. There's been considerable criticism, within the school system, that schools do not always have recess, they do not always have a lot of activity going on within the PE program, and that the only way you're really going to be anticipating and being active in physical activity in the school setting is being on some type of sports team. The problem with that, from just a logical standpoint, is that you can't be on a team. Most of the teams cost money, or the uniforms cost money. And so if you are in a low-income family, you're not going to have money for that. So that is one of the reasons you'll see a higher rate of obesity within a lower income population. And then, if you think in terms of the relationship between mental illness and obesity, it's usually that many individuals with some form of mental illness or a mental health disorder do not exercise. They may be depressed, and they're eating just grazing during the day. They're not eating well. They have a food. There's a lot of literature now about food addiction, and the fact that they are looking at the brain to see if there's some kind of a point in the brain that is correlated with many people with food addictions. And comfort eating and drinking. And let me emphasize drinking, because we know there's a high rate of drinking in our teenage population particularly. And then medication. And medication is one that I think, as a dietitian, when I see a client and do an evaluation, I can always look. I get a list of the medications, and then I have a food-drug-nutrient interaction book that every dietitian ought to buy, because it's helpful to be able to look it up and tell you what it does. Now, I think we all know the nutrient needs. And are the nutrient needs different? Well, they are different if you have an obesity problem. And there are, if you've heard the lectures this morning, there are some nutrients to look at if the individual you're working with has a mental health problem. So based on what the RDA is, for this population, an average from the age of 9 to 18. For the males, it's of 2,500 to 3,000 calories. For the female, it's 2,000 to 2,500 calories. That only applies if that person is having a normal metabolic rate and if that person is being is active. And if they don't have a disability. So it's very possible that in doing an assessment, you will not find that being the need. What about protein? Now, if you are, let us say you come home from your internship or your traineeship and you're tired and you're going to prepare your meal. What is the average thing you'll do? Say you come home and you're tired, had a really hard day in the internship, those preceptors have worked you to death. So what kind of supper will you fix? Will anybody tell me? Cereal. Surely there's a Martha Stewart out there. That
I made a quesadilla.
Okay, what did she say?
She said a quesadilla, something quick.
Oh, she does a quesadilla?
Yeah.
I'm pretty impressed. Now, how many vegetables do you have with that? Who all has at least 2 vegetables with their dinner at night when they come home from the internship tired? How many people? Well, I don't see a whole lot of hands, folks. Is it that we can't get our hand up this high, or we're just not putting it up there? I saw at least 2 people. Those are, I don't know if we give rewards, Emily, but we ought to be checking this out. How many people are tempted to stop at McDonald's or maybe Jack's or maybe Wendy's or maybe, well, there's surely the Dairy Queen. Well, I'm going to be honest with you. When I come home from clinic at 5 o'clock in the afternoon and I'm really tired, I have discovered that Arby's in Homewood have a $1 milkshake, and I get that milkshake. And that is the greatest thing for me of the whole day, is that $1 chocolate milkshake. I am pretty good about telling them not to put the whipped cream on top, though. Because they always want to put, and they even told me one time they'd put a cherry. I said, no, just the milkshake, no whipped cream and no cherry. That might have been the best thing about the milkshake, though, would have been the cherry. So I'm just saying that if a person is tired, if a person they're not always making sure, and our clients, that they're getting exactly the amount of protein they need each day. And they're certainly probably not getting the amount of fat that's recommended. Now, the other thing, I'm going to come to fat, but what they are going to get are their carbs. And and if we know that generally it's recommended that you're going to have 50% of your calories coming from carbohydrates, we know that we want them to be low in sugar, and we want them to be whole grain, and we want them to be the complex carbohydrates, and most of them coming from fruits and vegetables. Now remember, I didn't see too many hands about vegetables at night when I asked that question. And I think that if we're not having, all of us having the number of fruits and vegetables we should have during the day, we should never be surprised that we find that in counseling. And we should never be surprised in kind of the fact that when we say, I want you to add this to your diet, that it doesn't always happen. And particularly it doesn't happen when people are having problems. Now the fat, again, and I will say this in our menu plan at Glenwood, we have the menus planned to match school food service, and school food service has everything at 30%, no more than 30% of the calories coming from fat. That means that only 1% milk is served there, and we had a lot of things to do with the menu to accommodate that, particularly in the adolescent population, because they were hungrier than they were being provided. We also have heard today, and if you read through the literature, you'll find that the fatty acids, the essential fatty acids, are extremely important, and is thought that in some studies they actually prevent depression, but certainly they're important to be included in the diet. Again, that sometimes becomes difficult. Well, and so we know, I'm going to skip this because I need to ask, Emily, when am I supposed to be finished?
12:30. 12:30 is whatever one.
So I have about 10 more minutes. Okay.
You have 20.
We'll do it. Don't worry. And so we know that the omega-3 and the omega-6 fatty acids, essential fatty acids, are important in the release of serotonin, particularly in catecholamine. Now, I think that when I was in training, I don't think I even knew what serotonin was. But when I began to work with inborn inherited disorders of metabolism, I began to learn about serotonin and the neurotransmitters that didn't get into the brain in the way that they should, and that was one of the reasons that an individual with an inborn error, say as PKU, had mental retardation. So the importance of the neurotransmitter is like when your computer doesn't work, that they're kind of like the little computer transmitters that we are all so dependent on. And I would have gone back to school and majored in essential fatty acids, I think, after a few lectures I went to, finding out how extremely important they were, and I didn't always know that. I also, there was much about the brain that I didn't learn in school, that I had to learn by Con Ed and by just studying about it. And there's a ton that I still need to learn. But I do think that one concept to take home is that we should be thinking about the brain. We should be looking at, is there something I can be doing in my practice to make sure that that individual is getting enough of something. And I was interested in one of the reviews of the papers that I did, that there is a list of lab work that can be asked for that is not in your usual CDC or CBC or lipid or protein, and that contributes to whether or not that person has a good level in their blood of the essential fatty acids. Well, we've always known about the B complex. And we certainly learned all that stuff about pellagra and berry. Don't you remember learning that in your nutrition classes? Okay, well, there's more to learn. And it also has a lot to do with your, the function of the brain. Folic acid deficiency may be it is thought that it's more widespread than expected, even though we have fortification of the food supply. Now, why do we have fortification of the food supply of folates? Because studies, at least 20, maybe 30 years ago, discovered that a deficiency of folic acid was a contributing factor in spina bifida. And therefore, folic acid, folate supplementation should be done by everybody prior to pregnancy. In addition to that, we had supplementation of the food supply, but it's still, in some of the studies have found that it is still not as sufficient in a person's diet as it should be. And of course, how do we get that? Well, we eat a lot of green leafy vegetables, we eat orange juice, we eat legumes, we eat whole grains, and the surveys by Haynes have demonstrated that those are not always adequately taken. So what does that mean for us as a profession? It means that we need to be doing much more nutrition education, and I think finding out how to do it. And I'm very pleased to know that one of your speakers is going to be here all about the use of the media, because everyone seems to be on Facebook, but not everybody's telling me that they had a great bowl of whole grain oatmeal for breakfast. That's usually not what they're telling me. They're usually taking a picture of them on some cruise. And nobody wants to be on a cruise right now, so I'll skip that. Then we know that there are low stores of iron, which and what have we done? We've done something good in public health with that when we got formulas fortified with iron, and we got low-income women on the WIC program where they can get their formulas, and that has a lot to do with brain function. And we had a lot at one point in this country of severe anemia, particularly among children and older adults, let me say. And then zinc also is involved in cellular metabolism. Now, at one point in time, evaluating people for zinc was very trendy in this country because there had been some studies done in Colorado showing that zinc deficiency was leading to shorter growth and length. That sort of went out, but now we're back into looking at zinc, and particularly in the mental health literature, you'll find quite a bit talked about zinc. And I was interested that in looking at some of these articles, that the number one thing they put down as your best source of zinc was oysters. Well, now, unless you spend a lot of money at the grocery store or you're on the beach at Gulf Shores, you're probably not eating a whole lot of oysters. But there are many other sources of zinc than oysters. Well, I just thought that it was interesting that they put it at the top of the list. And then with magnesium, and then we had vitamin D deficiency. And I wanted to say this minute, in the studies about vitamin D, there was an association both with depression, cognitive disorders, and bipolar and schizophrenia. And I want to say I was interested in that because I have noticed in the medical evaluations of the individuals that I see at Glenwood that almost everyone is on vitamin D. Almost everyone is on a vitamin supplement. And that is good because now I'm going to be showing you soon the medications that they're on, which have a lot to do with their weight management. And this is what we do. This is what our nutrition assessment looks like in these values. And we do not get a 3-day record, but we do get the menu. We are not able to find out. I just took off the recording. You're not going to like this. Okay, I got it back on now. We are able to see the menu. We are able to see the central menu, but we do not know exactly what happens to the menu when the meals are planned and fed in the group homes, which is done, what is done at night. And the family consideration is extremely important because the clients at this particular facility can either go home on the weekend. Some of them are only there in the day, and so they go home every day, or and then they go home at holidays, and some go home for a week or so, visit at a time. And at that time, much of what has been done in the facility, nutrition-wise, is tampered with because maybe the client gets home, he's in a different environment, she's in a different environment, she starts having acting out behavior, and they control the behavior with food. And so one of the things as a dietitian that I have tried to do, if I am talking with the family, is getting them to use a different reward. Find something else that will be a reward rather than going to McDonald's and getting a Big Mac, which was one of the big things some of our clients would do. So now let's talk about those medications. Every single client I see is on 2 or 3 medications. Now, look at what these, and so, for example, for depression, many people in the community, many of your friends may be on Abilify, I'm not going to try to do the generic terminology, Elavil, Zyprexa, these are depression medications. Look what they do. They increase weight, they cause drowsiness, they contribute to constipation, and they stimulate appetite. Then look at Zoloft, Risperidone, and Seroquel. They increase appetite, increase weight, and magically, this is a magic phrase to think about, dry mouth. So what does that do? They want to drink more. And so you want to make sure what they're going to drink is water or unsweetened tea, although it has caffeine in it, but water, but definitely not soft drinks or the power drinks. But what do many clients want? It's not water. It's usually, the power drinks are super popular now, and of course the sodas. And phenylazine, another one, increased appetite, increased weight. These are all medications used for depression. Now, these are antipsychotic medications, and these, it's not unusual for me to have a client that's on something for depression, but also on an antipsychotic. And these are usually used for the acting out behaviors. And if you look at them going down, each one of them, they increase appetite and they increase weight. So you've got to have some type of food modification within an institution if you have that in order to not contribute to weight gain. So how do we handle that? Well, we have a general menu that is relatively not over 2,000 calories, and it's mostly 1,800 to 2,000. In addition to that, everybody has their weight and height taken and their blood pressure once a month and plotted. Everybody has lab work done once a year, so that as a dietitian, when I'm in there doing an evaluation, I have 3 things to look at, in addition to looking at the client myself, and finding out from the group home people how the client acts during mealtime or how accepting they are of the meals at home. And these are the anti-seizures. A number of individuals with autism also have seizures. So these are the seizure medications. And look what they do. They increase appetite, weight. They, Dilantin, which I thought was out of use, but is still in use. I do not know if you know what Dilantin does, but in controlling the seizure, it often has a side effect of swelling of the gums, which then is going to make eating a little more difficult, particularly eating things like apples and things that are hard to chew. And then for Luvox, is what is used for obsessive compulsive disorder. And again, that's an increase or decrease in weight. Now, there are some clients that are on these that actually do have some anorexia. Then there are those who actually, they may have anorexia, or there'll be another one that it causes an increase. So, counseling recommendations. I don't think this is going to come as a surprise to any of you, but the time, if you're seeing an individual that's at home, talk to them about their meal structure. Talk to them about the times they eat. Are they eating it'd be good, it's always good to have breakfast, lunch, supper, not grazing, and then possibly not eating at 9 o'clock at night before you go to bed, unless these people don't go to bed early. But if you're dealing with an individual client, they will have a more normalized schedule. But in our facility, though, they're very structured about bedtime. But you see all the things that we list as good things for counseling. I think, though, that one of the things that's helpful to do, if the individual is conversant enough to do it, is to set a priority where they put the top priority of the one thing that they're willing to start with. Now, I just want to tell you very quickly about a girl that I have followed for 7 years at Glenwood. And she did not come there really because of mental illness, but it was her acting out behavior and inability of the school to be able to handle her. So if you look at her, she came for treatment of sleep apnea, severe behavioral problems, and pre-diabetes. They were concerned that she was going to have type 2 diabetes. Also, she'd been in public school, and her behavior was so that they could not handle her in the school. This is how much she weighed when she came in, 247 pounds, and she was 56 inches tall, which is 4'8". Her BMI was 97th percentile. I think her BMI was more like, I don't have the exact BMI, but it was at the 97th percentile. We don't want your BMI to be at the 97th percentile, but it was more in the 40 range. Then so we estimated her calorie needs at 1,716. Her energy intake at home, we had calculated to be 3,000. Why was that? And her protein needs were 52. Her intake at home was that high because she would go home on a visit, she would have a lot of acting out behavior, and to calm her down, her grandfather took her to get a Big Jack or a Big Mac. So in part of my counseling experience with him, actually, I was in their training meeting, their team meeting, and I'm talking to him on the telephone, talking to him about that we need to try something besides that her weight is very dangerous, and it is dangerous because she's prone, she could have cardiovascular symptoms, and also because of the prediabetes, she went into type 2 diabetes. She was diagnosed with that. Sleep apnea was such a problem that they had to use the CPAP on her at home, and she refused to do it. So one of the behavioral things that was done at Glenwood was to get her to use the CPAP. And she does. And then she was very, very anti-exercise, anti-walking. And so these were her medications, and these were her blood values. And you'll see her hemoglobin and hematocrit are fine. Look at that, the cholesterol is high, a little bit high, too high for a 14-year-old. And glucose was 120, and then you'll see her medications. And that medication, Topamax, was for seizures. So she did have seizures in addition. So she came in with a chromosomal disorder that had manifested itself into a mental disorder. Whoa. These are excessive. This is just some of the things that I found in the evaluation. Constipation was an issue. Why was that? Because she wouldn't drink water for one thing, and she wouldn't eat fruits and vegetables. So one of the things they worked on at Glenwood is getting her to accept at least some fruits and vegetables to try to improve this. These were her nutrition-focused findings. Number 2 in anybody with a chromosomal disorder is always important, and that's the low muscle tone. But then her inactivity related to walking, feeding problems. We were afraid she was going to choke because she was a fast eater. And so one of the things that many you'll find is putting an established time for eating a meal. And that it has to be eaten slowly, but it can't go on all day, and they can't get up from the table and leave the food and then come back. So establishing a meal pattern is one of the first steps that anyone ought to take, particularly with this population, but I almost think with maybe a normal population too. And then the constipation, and we've already addressed that. Okay, so she had a Z-score of plus 2.93, and you'll see this was her nutrition diagnosis. Intervention goals, and number 3, the first 3 we wanted to do at the home at Glenwood, but this 4th was the counseling of the parents and really working on physical activity. Now this facility has a swimming pool. This girl doesn't go in the swimming pool because she doesn't know how to swim, but she's being taught. And this was just the meal plan that we came up with. And number 2, providing the menu to when you finish and you're in this high-paying consulting career that I know you all are going to be in. If you are in a facility that has group homes, not only on the facility, but out throughout the city, one of the problems has to be, what are they doing? And what can you do to help them work with you on on the plan you have for the client? Okay, today she weighs 210 pounds. So in 7 years, she's lost 37 pounds. I'm not thrilled with that, but everybody says, oh, they think that's pretty wonderful. But I don't know, but if she had not been in a facility with a nutritionist that was looking at this, she might have been plus 37 pounds rather than lost 37 pounds. I wanted to tell you all one final thing, and that is for those of you that are interested in mental health from a nutritional standpoint, and or mental retard, cognitive disorders is the current term I should be using for mental retardation. If you find that an interesting thing and you belong to the academy and you belong to practice groups, consider selecting the Behavioral Health Nutrition Practice Group as one of your practice groups because they have an abundance of materials on working with this particular population and with the eating disorders population. And they are doing a series, they do a series of webinars, they have a series of handouts, and I have a sample of one of their handouts with me if anybody's interested in seeing it. But from a continuing education standpoint, it's a very good practice group. Now, does anybody have any questions other than how soon can we get to lunch, because it's back there? Okay, well you can if you have a question and you don't want to ask it in a group, and it's a burning question, you can just ask me over lunch. If it's not a burning question, you can ask that over lunch too. Thank you.